Good morning, everyone. We're going to go ahead and get started. Thank you for taking time out of your busy day to join this presentation on the CDC's Hepatitis C and HIV clinical guidance package. My name is Emily Bean, and I manage the Main Care HIV Waiver Program. The goal of this presentation is to provide an overview on their clinical guidance package, which contains resources for healthcare providers for screening, treatment, prevention, and patient care. In the interest of time, we'd ask that everybody put their name and organization in the chat so we can see who is with us today. And we hope to have time at the end for questions, but please feel free to put any in the chat as we go along. Joining us today from the CDC is Chloe Manchester, viral hepatitis epidemiologist, and Emily Kaysen, HIV and STI epidemiologist. Once again, thank you, and I give the floor to Chloe and Emily.
All right, I'm going to share my screen and then Emily can get us off.
All right, thanks everyone for joining us today. Chloe and I are very excited to tell you a little bit about our hepatitis C and HIV clinical guidance package. Next slide, please. So our clinical guidance package is supposed to be sort of a ready-to-use resource for healthcare providers and healthcare practices who are looking to increase HIV and hepatitis C screening and treatment, promote prevention strategies for patients at risk, and improve patient care in a syndemic approach that addresses the intersectionality of HIV, viral hepatitis, STIs, and harm reduction. So a few notes on this clinical guidance package. It references previously established recommendations, mostly from US CDC and the American Association for the Study of Liver Diseases, and it provides recommendations based on best practices, but of course, clinical decisions should always be based on the individual patient's needs. It's designed for adult patients only. Pediatric patients may have unique needs that are not addressed in this toolkit. And there's links throughout the document that provide a lot of additional detail and external resources. And those may need to be accessed for the best, comprehensive guidance, especially related to treatment, because those external resources are constantly being updated by the organizations that maintain those resources. So the best way to make use of this guidance document is on a device that has access to the internet rather than printing it out. And includes a lot of citations and endnotes that reference what's within the document as well as some additional resources. So we definitely encourage you to look through all of those various links. Next slide, please. So in order to address HIV, viral hepatitis, substance use, STIs, homelessness, we need to use a syndemic model. Syndemics occur whenever two or more diseases or health conditions cluster and interact within a population because of social and structural factors and lead to an excess burden of disease and continuing health disparities. And we know that all of these conditions really coexist and overlap. Injection drug use is the most commonly reported risk factor among new hepatitis C cases in Maine, and about 15% of people living with HIV in the US are people who inject drugs. There's also an outbreak of HIV in Penobscot County right now. It's been going on for a little over a year. And currently there have been 23 new HIV diagnoses associated with this outbreak between October of 2023 and this past week. And prior to this outbreak, there were only about 2 new HIV diagnoses per year in Penobscot County, so this is quite an increase. All of the individuals who are associated with this outbreak reported injection drug use. All but one case is co-infected with hepatitis C, and 91% of cases were unhoused in the year prior to their HIV diagnosis. So this outbreak in Penobscot County really encapsulates the importance of a syndemic model for prevention of these conditions. Next slide, please. So the clinical guidance package starts with this flowchart that you see on the left-hand side of this slide. And this is kind of designed to be your overview to use for each patient visit to walk you through screening recommendations, testing, risk mitigation, and follow-up. So you can see on this slide an overview of some of the sections that are within this guidance, and we'll go over some key takeaways for some of these sections this morning. Next slide, please. So for screening recommendations, the most important kind of key takeaways related to screening recommendations are to identify whether a patient engages in IV drug use, non-IV drug use, or sexual activity that presents a higher likelihood of exposure to these infectious diseases. So it's important to take a thorough patient history, as patients who endorse certain behaviors are at increased risk for infection with HIV or hepatitis C, and those patients should be tested more frequently as long as they have ongoing exposure risk. Regardless of the patient's risk factors, universal HIV and Hep C screening is recommended for all adults at least once in their life, and there's additional screening recommendations for pregnant persons. Next slide, please. So this slide is an overview of screening recommendations frequency for different conditions. So routine risk-based screening is recommended for HIV, hepatitis C, STIs, and Hep B for patients with ongoing risk factors as long as that risk factor persists. And if the person has no currently ongoing risk factors but has engaged in some sort of risk behavior since their last test, then we would also recommend testing that person at this visit. Risk-based screening should be done at a minimum annually, but it can be up to every 3 to 6 months, depending on the person's ongoing risk factors. And in the context of certain situations, such as this HIV outbreak in Penobscot County, we sometimes recommend more frequent testing depending on the context. So Maine CDC is currently recommending more frequent HIV testing as a result of this outbreak in Penobscot County. So we're currently recommending testing every 3 to 6 months for folks with ongoing exposure risk. And then for universal screening recommendations, there are universal screening recommendations for all adults for HIV, hepatitis C, and hepatitis B. And then in pregnancy, screening is recommended for HIV, Hep B and C, and STIs. And you can find a lot more information about screening during pregnancy in section 2.1 of the toolkit. In terms of testing sequence and what test to order for hepatitis C, the sequence starts with a Hep C antibody test. And if that's reactive, the next step should be a Hep C RNA to determine if the person has a current hepatitis C infection. And for HIV, the testing sequence starts with an HIV antigen antibody test. And if that's positive, an HIV 1-2 antibody differentiation test should be done. And then as a third step for HIV, if the antibody test is indeterminate, that should go on to an HIV NAT. And in all of these cases, we really encourage you to choose a test that reflexes automatically to the next step in the testing algorithm to avoid delays with having to ask the patient to come back in for an additional blood draw if they needed further testing. For syphilis, both the traditional and reverse sequence algorithm are acceptable. We don't encourage one versus the other, but as with HIV and hepatitis C, we encourage you to choose a test that reflexes to the next step in the algorithm, again, to reduce delays, to reduce unnecessary venipunctures, and really just to make sure that we get the full picture of whether this is a current or past infection. And at this point, I'll turn it over to Chloe to talk about risk mitigation and prevention.
All right, thanks, Emily. So Emily shared a lot of the testing, and then so that's when we think about the patient interaction as a sort of a process, that's sort of the first step that you'd want to do. The first interaction would be determining what to test for and then performing those tests. But as we think about each patient and their syndemic needs and the syndemic risk factors associated with their behaviors and their lifestyle, we wanted to make sure to include a really robust set of resources around risk mitigation and prevention, whether it's prevention of HIV, STIs, or hepatitis C, but also other risks associated with IV drug use and homelessness, mental health needs. So those are all included, and we'll give a quick summary of what those include. So some key takeaways about this section and this component of the toolkit is that regardless of HIV and Hep C results, as I mentioned, each interaction is an opportunity to discuss the steps to reduce transmission of these viral infections through prevention methods. Now, these might be different based on the risk factors that the person identifies, but it's really an opportunity to mention all of them, really elucidate the types of behaviors that the patient is engaging in, but also to provide that education in case the patient doesn't disclose certain risk factors. So providing information about how to reduce risk of transmission during sex, if applicable. And then similarly, provide information about how to reduce the risk of transmission during IV and non-IV drug use, if applicable. So we have lots of resources in the toolkit around harm reduction. So that obviously spans a wide range of needs and prevention activities beyond just preventing transmission of infectious disease, and beyond the ones that are listed or highlighted in the toolkit here. So the key areas that we are addressing in the toolkit in terms of risk mitigation and prevention is discussing safe sex practices, discussing harm reduction practices, hepatitis A and B vaccination, evaluation for PEP and PrEP, and then referrals to other resources as needed. So ideally, all or most of these services can be provided during that same visit in a clinical setting. For example, PEP and PrEP, administration of Hep A and B vaccination. Those can be done in the clinical setting, but also discussing safe sex practices and harm reduction can all be part of the patient interaction. Some of these may require additional training, maybe referring to additional resources if they're not common practices. They might involve referrals if that's possible, but we want to avoid any opportunities for loss to follow up or any opportunities that may lead to that person not seeking those behaviors. So whenever possible, housing all of those services in the same location is ideal, which is why we included everything in the toolkit here. Treatment and linkage to care is another big component. So as Emily mentioned, most of the very specific recommendations when it comes to treatment are links to other sources, mostly AASLD for hepatitis C treatment, for example, because these are much more nuanced. They get updated on a semi-regular basis, and we didn't want to include everything in one place, making this a really bulky toolkit. So some key takeaways about the process of thinking about treatment and the use of this toolkit is to initiate treatment or rapidly link to care to reduce the viral load, improve patient outcomes, and further transmission and prevent further transmission. Primary care providers can treat HIV and Hep C. This is a really big one that we hope the toolkit will empower or enable, evaluate the presence of any co-infections, especially HIV, Hep C, and hepatitis B, prior to initiating treatment. Initiate treatment or rapidly link to care if the patient is positive for any STIs, including gonorrhea, chlamydia, or syphilis, and then report positive results to Maine CDC. So there are some drug-drug interactions as well as some contraindications for individuals who have co-infections. So we also have recommendations around how to approach those situations. And the importance of screening for all of those infections prior to initiating treatment. And again, this one of the big takeaways is the ability to provide treatment or at least a prescription on the day of diagnosis. So being able to treat and then, or test rather, and then treat within the same facility, within the same practice is the goal. And that's pretty much it. I'm not going to go into all the details of treatment and those specific recommendations because those are links to other resources that are all included in the package. So we have some discussion questions for you all, sort of around how you might use this toolkit, how it can be helpful in your setting. So I'll start with those, and then we have plenty of time, so we'll do any questions from you all after these, and you can feel free to put them in the chat, or we can just or just come off mute and ask them. But first, wanting to sort of discuss some of these thoughts with you all. How can you make use of this clinical guidance package in your practice? I don't know if I'm seeing some familiar faces, and some people I've put where they are from in the chat. So I do see some people who are coming from a clinical practice setting, So would love to hear from those folks about how they might make use of this clinical guidance package in that practice. Or we can feel free to answer any of these questions, potentially using the clinical guidance package as a training tool for newer staff or just-in-time training if you're considering expanding the types of services offered. Suggestions for updating the guidance package. The link is there in the chat if you haven't had a chance to take a look at it, or just based on the information we shared. Feel free to make suggestions or ask us about what you think should be in there, and we can let you know if it is. And then how else can we disseminate this guidance package to other providers or organizations? And then any other ways we can support. So I'll give it a few minutes just to, open the floor.
I just want to say, I think that participants can unmute themselves. I'm watching chat though, so let me know if it won't let you and I can unmute you.
So,
I'll go ahead and jump in.
Hi.
But I am not from a clinical practice. I am Sybil Mazerol-McCrae. I work at the Office of Behavioral Health, and I work on the certified community behavioral clinic model, which we just implemented in March. And one of our newly implemented providers is CHNCS, who works right in the heart of Bangor. They have been very present in the homeless encampment, utilizing some of their outreach programs like the Options Liaison Program and their Path Workers as well, to establish a presence. I did take that link that you guys provided in the chat and sent it over to their clinical director. And one of the things that we were able to do in partnership with Courtney Pladson from OMS was include HIV case management within the case management definition of the model. But I do think some more support to these newly implementing clinics around, they do have a health promotion service category that's required for CCBHCs, which can include HIV and Hep C screening, and then linkage to care, plus some support for that treatment adherence. So I think that there is an opportunity to further discuss this between our program team and the work that you guys are doing to provide support to our CCBHCs. Those are my thoughts.
Thank you. That's great. We're doing a little bit of work already with OBH on our corrections task force, and Helen, who's also on the call, and I are doing that, and really trying to reach across agencies and divisions, because there's such an overlap, as you know, with OBH and with infectious disease. I think there's a lot that we can do working together. So I will reach out to you, and thank you for sharing that, the toolkit with them. And yeah, that's great.
Chloe, did you see the note from Susan Whitaker at Maine Primary Care Association in the chat?
I did.
Great.
Yes, thank you, Susan. And if Susan, if you wanted to elaborate on that at all, so I think it would be great if FQHCs could make use of this. Is there anything that we can do to I don't know, help with the use of it, or help incorporate it into programs? Any other?
Right. Well, we'll definitely reach out if we think that your involvement in a webinar of some sort would be really helpful for our FQHCs. We do have a UDS quality measure related to HIV and linkage to care that we need to be satisfied. So FQHCs are already focused definitely on this, but also there has been some care management. There has been a care management company that's been taking care of main care patients with HIV that has just gone out of business. And so those patients are sort of left without that case management service. So some of our FQHCs are trying to pick up the slack. So I thought this would be really helpful for them, and education is good. So we really appreciate this this package. Thank you.
Thanks for that. I don't know if you've had a chance to look in the toolkit at all, but it would be helpful to know if the document as it is a useful resource or if it needs any additional add-ons. Do things need to be turned into one pagers that can be printed out? Is it one of the things I'm curious about is like Emily mentioned, it's because there's so many links, it's best used as a accessed on a computer on where with internet access. Is that realistic? Does that create a hindrance at all if someone needs to be using it with a computer, if they don't necessarily have a computer when they're speaking with a patient face to face? So sort of curious about the user experience for providers as they're using the toolkit, so that it's really helpful for, what it's intended to do.
Mhm.
Yes.
Great. We can definitely give you some feedback on that.
Susan just wanted to mention too that the recording of this session will be posted on MaineCare's website within a week or so, in case that's of use to you.
Wonderful. Thank you.
Any other thoughts about how we could make this more useful, ways it can be incorporated into training? Just reading Jasmine's comment about the package is going to be super helpful in training staff and providing guidance to community members accessing the testing. I'd love to support in having some connections to the state to refer individuals for confirmatory testing. Yes. Actually, Jasmine, do you mean for Hep C or HIV or both? I know it's been a huge barrier. Both. Um, yeah, that is so curious. Are you in a healthcare setting, Jasmine? I didn't see where you're from.
She's with the Horizon Clinic.
Okay, excellent. Thank you. I was so curious, what do you currently do for confirmatory testing at your clinic now? Is it a venous draw that has to be sent out to a lab, or you don't really have any options? That's okay. Totally fine. I can keep talking. So for hepatitis C, I mean, I think the options for Hep C, RNA confirmatory testing, there are new options. There's a point of care RNA machine that can, I think it's from Cepheid, that can provide confirmatory qualitative results within 40 minutes or less. And we also have dry blood spot testing, which does have to be sent out, but that is also a confirmatory test that does not require a venous draw. So if you're looking for testing purposes, ability to do confirmatory testing, those are two newer options. We're working on making those available through the state, but I know that hasn't happened yet, and that's still a challenge for a lot of people, or a lot of facilities. Emily, do you want to talk about HIV confirmatory testing?
Yeah, so one option in terms of reducing the need for blood draws for HIV confirmatory testing is to do like a sequence of 2 different rapid HIV tests in the field. And if we get 2 different rapid reactives on like different brands of test, we would consider that a confirmatory test. So there probably will still be the need for blood draws in the future as that person is engaged in care and getting CD4s and viral loads done. But at least while you're out in the field, if you have the availability of 2 different types of rapid HIV tests, that will mean that you can hopefully get a confirmatory test done while that person is with you without needing a lab. So I'd love to connect you with ESB, who does our CTR training, if you're not connected with them already, because they're doing a lot of work to try and make sure that everyone has access to like training on how to use multiple types of tests. And I think that would probably be my best recommendation for like without sending someone to a lab for a blood draw for getting a confirmatory in the field.
And then there are some links and resources in the clinical guidance package about referrals. So again, referral is not ideal because we want to be able to provide all the services on the spot, including confirmatory testing, but there's links for referrals for confirmatory testing. That may be what Helen posted in the chat. So that may be referring to to Helen, to our Hep C referral line to help connect someone to a clinic that's nearby where they can go and get some confirmatory testing done. But I think trying to find an option that's available in the field is what Jasmine is looking for, and there are some options for that. Yeah. Any other questions for us?
Thanks, Emily. Thanks, Chloe. I think if there's no further questions, I'm going to go ahead and stop the recording and end the meeting. Thank you, everyone, for your time today.
Thanks, everyone.
Thank you.